What are the goals of therapy here anyway? What are you looking for first?
Viral suppression.
Okay.
Like we mentioned earlier, HIV is something where you can manage it. Your viral load can go suppressed, can be undetectable, and undetectable can be untransmittable. There does not need to be new cases of HIV.
Oh, wow. There does not. Every time somebody opens his or her mouth here, I'm just shocked with wonder and happiness.
If we could test everyone in America and everybody who's HIV positive mandate in some way that they all get on therapy, and if we do directly observed therapy where we watch everybody take their medicine 100% of their time, we would eradicate transmission. Everybody would go to undetectable amounts of virus and they would no longer transmit HIV.
You can't keep people from crossing the street on a red light. How are you going to get them to take drugs?
Well, you make things simpler. You make things more doable. And I think that's part of our discussion today is what's our current perspective on management so that the maximum number of people will be successful.
You know, it seems to me that there are two separate branches that all three of you have mentioned. The first is the individual who's HIV positive. Treating that person keeps the viral load down to undetectable. T4 cell counts go up. So that person stays healthier. But then there's this whole public health aspect to it. Definitely. And that's got to be factored into your calculations too, right? It may be expensive to treat somebody individually for HIV, but you're going to keep a whole circle of people from getting it.
Right. No, absolutely. You know, it's just the total cost of the category is increasing, but it's driven by the drug prices and the drug increases, and so that's where the conversation needs to be. But you're absolutely right. I mean, we want to treat these patients appropriately. There's not a disconnect in terms of what our goals are.
You know, I was just thinking about this as you were speaking, and two things occurred to me. Yes, it would be cheaper if nobody got AIDS from HIV, but in a most bizarre and dark way, it might be cheaper if they got it and died. I mean, you know, there's that too.
Yeah. But prevention's like any other disease. Prevention's usually more cost-effective than treatment. So
we don't want the second alternative.
There are definitely better ways to approach this problem.
And whether that's preventing HIV or preventing advanced HIV once somebody has HIV from effective
transmission
care.
or anything else, right?
But once they've got it, you can still treat them. Yes?
Yes.
Yeah, we can treat very effectively.
One of my concerns is and I don't work for the pharmaceutical companies, but what I see as some of the benefits that we've seen through new drug development over the last 20 years have been improvements in safety, improvements in tolerability, improvements in simplicity, but that have come at a cost. So the balance is, the trade-off is, do we want to go backwards from a payer perspective? Do you want to say, oh, I just want to take the cheapest therapy, but realize that it may be more problematic?
Or can we take a step sideways? You know, I don't think anybody agrees that we need to go back to the days of the cocktails, as you mentioned. You know, the 20 tablets 4 times a day. But is there can we do a better job of going from, say, 1 tablet once a day to, say, 2 tablets twice a day if it saves a lot of money? Are there ways, or is that just, you know, so I think those types of conversations.
Impede adherence, and then you've got a problem with that.
Yeah, so we don't want to affect adherence. But I would argue that 2 tablets once a day or 3 tablets once a day is very different than 20 tablets 4 times a day, like back in the old day. So.
Well, I mean, that's a reductio ad absurdum, right? Nobody's going to go back to 20 pills a day.
Yeah. But I think if you look at the market, correct me if I'm wrong based on what your experience is, but the majority of patients are still not on single tablet regimens for whatever reason. So is it appropriate for us to collectively move in that direction, or are there opportunities to take advantage of generics and maybe more cost-effective single tablet regimens and other things that we haven't had conversations about previously?